Good evening, everyone. It's Wednesday, June 26th. We're here for a work session of the City Council. We'll begin, as we always do, with public comment on non-agenda items. If any member of the public is wishing to speak to the council on an item that is not on our agenda, go ahead and come forward in the room. All right, seeing none, I will close public comment and we'll open our work session, which is the Fitch Consultant Report on City of Laramie EMS Services. Chief Johnson, welcome. Thank you for being here.
Honorable Mayor, members of council, thanks for making time tonight for us to get this presentation before you. It's a comprehensive review of the emergency medical service that we've been running. We've been in partnership with IMH to provide EMS services throughout the city of Laramie and Albany County for 45 years now. Since 1979 is when our original agreements were. There's been several agreements over the years, and recent history of our agreements, we worked on the agreement that we're under now we actually started working on it in 2013 and came to terms in 2017 on a 5-year agreement. Toward the beginning of that, it worked real well for both parties. Toward the end, things changed in 5 years, and we've been working on updating that agreement since about 2022. So we're working on the details, and city team, hospital team, we look at analyze data. We come up with interpretations, and we have differing judgments based on the same data that we look at, different interpretations. So we jointly contracted Fitch and Associates to do this study for us. At this time, I won't talk. I think the last couple times you've seen me, I've rambled on a long time about things. So I'll keep my part short tonight, and I will introduce to you Mr. Todd Sheridan. He's a junior partner for Fitch and Associates, and he'll be doing the presentation. So.
Thank you, Chief. Welcome.
Thank y'all for having me.
Yeah, thanks for being here.
All right. If y'all don't mind just a second, I'm going to get set up so I can see my notes while we're taking off for a minute.
You take as much time as you'd like.
All right. And I just got glasses too, so I am learning that process as well. Many of y'all I can tell, so if I start doing this and trying to see you, I apologize on that too. All right, let's make sure the clicker goes. All right. We're perfect. All right, so first off, my name's Todd Sheridan. I'll kind of introduce myself in a minute, but first I want to say thank you. Thanks for having Fitch and Associates and being able to be a part of this. One of the real unique moments that we saw when we came together was, and it was, and I'll say unique, is two parties coming together to look at something collectively to say, how do we move this forward? Since the inception of really this agreement back in 2017, moving forward to now, it was kind of imperative to walk through what changed, not only here locally, but in the industry. So today we're going to walk through those moments collectively together. I'm going to spend we'll call it about 40, 45 minutes walking through the presentation. I'm going to stop periodically as I go through and just ask to see if you have any questions. So as I get on a roll, I'll stop at various points and times and see if you have any questions so we can keep the flow going, but I can also in real time answer a lot of your questions. So a little bit about Fitch and Associates. Fitch and Associates has been around for 40 years. Now, people don't realize we have not only had our original 3 partners, and we transitioned to now a new set of partners because, well, the original ones were allowed to retire. So we will say it that, okay? We let them retire out of that. What people don't realize about our firm is they think of us as EMS consulting, and that's what our origins were. We went back and set up a lot of the largest EMS systems as a consultancy. We've been in all 50 states, all provinces in Canada, every continent except Antarctica, because who wants to go there, right? And so as a firm, we've developed both a methodology and a process in which we go after and really work with our consultants, or our different consultancies that we work through. But what people don't know about Fitch and Associates is we're also a management firm. So we go out and various organizations that are in trouble, or maybe they're being merged, acquired, they need help financially or operationally, we will come in and physically manage your company. And that's where I spent for about the last 10 years with the firm, is operating as the CEO, executive, or whatever within hospitals, not-for-profit, for-profit. Currently right now, we as a firm we're hired for Fort Worth, Texas. I just came from Fort Worth, Texas to Laramie, so one cowboy state to another, right? So walk in, and we've been contracted to help with that transition from a private entity into a municipal, which that has its own kind of uniqueness when you think about it, from accounting to profit and loss statements and all of that. But our firm manages both. And so for the past 3 or 4 years since physically managing companies, now I oversee a lot of the management services and consulting part within our firm. Reason why I tell you all that is our management services, physically running companies, helps us both keep our finger on the pulse operationally and financially and how the systems operate, and it helps inform our consulting. So as you see, when we start walking through today how we build systems, how we structured, how we broke down your system, the reason why I did is you're no different than when I just left Fort Worth, Texas, in the process in which we use, and then how we break it down financially so we understand what the net impacts are. Now, geographically, you're different. Operationally, you may have some different nuances, but we walk through really systematic from a methodology perspective as a firm. Now, a little bit about, I won't go through all in detail, and a lot of the PowerPoint slides are going to be behind it. If you want to read it, great. I just kind of talk. So as we walk through, I'm just going to walk through this high level at the slides. But really, just to kind of give a broad stroke, the goal of this study was being an independent third party to help understand both 911 where you're at and as an interfacility hospital transport agreement where you're at, and then see if you can marry both what's happening in 911, what's happening with the hospital, and help understand what could be a win-win situation for all parties contractually moving forward. What we had to do is break down the operation, and you'll see where we separated the 911 service, where we separated the hospital service, and where we tried to understand the financial picture between both. Now, nationally, the financial picture is not really good for EMS, and costs are being shifted to municipalities and hospitals, and we're going to talk about that more later, and how Medicare has not kept up with the times as it relates to total cost of service. We also understand that when we walk through this presentation, we did produce our draft report. We provided that to both IMH and the city. Since then, we've been working with the city. Since the city's asked us to come here and present, we haven't presented yet or heard from the hospital on any presentation there, but we're more than welcome to do that. We are very transparent as a firm. We want something that's actionable and implementable for you all. Because the ultimate choice here is we do not provide, we'll say, direction for you. We provide options, information, and a data point for you to be able to make a policy decision. So as you'll walk through, there's no one-size-fits-all in our report. You'll see we've got 3 options at the end, and we're going to walk through it, and that helps you as policy leaders to help set direction on what you feel is right for your locality. So I'm going to kind of have a couple spoiler alerts right here before we go through. In short, what we found is that collectively the 2 parties working together is better than separate. Now, you could separate the situation, and the hospital could potentially bring in another provider and do their hospital transport work. That could happen. But with the finite number of resources you have, the finite number of personnel, and let's just face it, neighbors helping neighbors, or the extension of a 911, you go to the hospital, you get stabilized, but you need to go somewhere else. If you have a systematic approach, which if this is designed right moving forward and is a win-win for both parties, we feel this could be a good situation of you two staying as a partner moving forward. So that's kind of the spoiler alert, because the reality in this whole situation is the fire department's doing what they need to do for 911 and taking care of that 911 emergency response. But there has to be a dedicated level of service for that, as well as the hospital has their work and need dedicated level of service. Because things changed a while back with the Affordable Care Act, in where even hospitals had to specialize at locations, leaving the idea that somebody may leave your community, single hospital, and have to be moved to another hospital for definitive care. That's just the reality of the world that we live in. Let me see if I can move this slide. So really, as a method, the way we started to break down and better understand both operationally and financially, we used and deployed what the firm has done for years. We use kind of an ABCDE approach in our methodology. What we want to do is assess the situation. And the way that we do that is right on the engagement. We provide what's called an information data request. It's about a 200, 250 point document. We ask for everything from how's the system set up, your licensing, all the way through your data points for, we'll call it the raw data for us to analyze. Because we want to ground what we make as recommendations in the facts and the data. What does the operation say? What does the data say? And then ultimately, what do the finances say? And then there's some qualitative situation after we've analyzed, created a data report. We then come on site and listen to people. We hear what they have to say, because a lot of times you have to listen to what the firefighters, the police officers, paramedics, hospital folks, what they need to ultimately be successful, because the data only tells you the past, doesn't all tell you the future. So hearing from folks what their needs were important to us. Ultimately, what we then did was we consolidated all that information, created what you found as the draft report, and are here presenting that to you. Now, as we walk through today, what we start with is what we do is the critical findings. Then we're going to talk about how we analyze that. We're going to financially ground it, and then we're going to walk through as what we call the pathway forward. So in our critical findings, there were 8 specific critical findings that we walked through. And when we say critical findings, these are just the things that popped out at us that were really high level. We felt it should catch your eye. These are things that you should pay attention to from a policy perspective or from an operational, a financial. And so we pulled those out specifically to talk about today. The first thing I want to talk about is the ambulance personnel lease agreement is outdated and ineffective. Okay? That agreement now has been out since 2022, and I want to just say purposefully. It's continued operating at that as a, we'll call it a strategic decision by both parties. However, it's up for renewal. But both parties are continuing to try to figure out some type of win-win. But what we mean by this ambulance agreement is outdated, it does not reflect today's operational reality, financial situation. And when we start to think about that in 2017, you'll see us drive through this more. The revenues that came from both programs, and especially the interfacility transport, it matched the expenses. And when they designed the system, they designed in such a way that the hospital did the billing, they had a certain lease payment they paid per month, and if they collected anything more in revenues that were above any type of payment that was owed to the hospital for their services, then they would pass that revenue back to the ambulance company. However, in that agreement lacked the true up. So they trued up the revenue, but there was lacking in truing up of the operating expenses. And since 2017, there has been quite a bit of operating expense increase just across the world. So that happened here. So that's what we mean by ineffective. It also has put kind of an interesting, we'll say, situation for you. And what we mean by that is there's a risk and liability moment in the way the system is set up. You're going to hear us talk about 3 units, 3.5 units, 4 units here 24/7 to operate. I'll dive into more detail to what that means, but right now, because of the staffing, at certain times, the fire folks, the EMS supervisors, battalion chiefs, have to make a decision. Do we not staff our 911 to the fullest extent, or the last unit to go help the hospital? Is that patient more critical, or is us a known patient versus an unknown? There is a complexity. There's also a workload complexity we'll talk about. So when we start thinking of the decision points, it's not clear because of the finite number of resources that you have in your system. So that's what we mean by there's a risk liability moment, because somebody has to make a decision on what's going to affect either a patient or the unit availability level for 911 response. Excuse me, response. Number 2, our system funding. So as I had mentioned leading into this, there's an imbalance of the revenues versus the expenses. At this point, and what you all have invested with adding another a peak a day resource. You've added civilian, we'll talk about that in a second. All that adding of funds or our operating expense, even though the volume has gone up by 10%, that revenue that came from that 10% volume increase, does not match the expenses. And so right now, you have taxpayer funding that is funding the fire service, an EMS agency, that is not offset by a private entity. So you're effectively subsidizing a private entity with taxpayer dollars to service the community. Number 3, you have an addition of a peak a day ambulance without increased volume. I just mentioned that. You only had about a 10% increased volume, but that volume revenue does not match the expense and the investment that was needed to cover both that and the expectations being applied to for overall system response. Interfacility transports, as I had mentioned, they have increased about 10% over the same time period, and this marked increase with both expectation increases by the hospital and when people need to be transported have an imbalance. One of the things I mean by an imbalance is when you start thinking of you want a 1-hour response time, or you want a 2-hour response time, or you want a 3-hour response time. Well, if 3 hours is what you want, a patient can sit there for 3 hours. We can go do another call and come back, right? But if you want a 1-hour response time, well, maybe that 3-hour turnaround time, I have to add a second truck. So that adds cost. Expectations drive cost. So if you think through that, if there's been an imbalance or there's not a proper workload or people are just walking down the hall and saying, hey, you just dropped off a patient, take this one, without understanding the impact that has to the system, ultimately you don't have a true balance of operations, and that creates kind of a not only increased volume, but the expectation is out of balance. Which leads into point 5, lack of systematic approach to interfacility transports. There lacks a standard in an operating workflow. Now, both parties have worked together to develop, we'll call it a one-pager, to try to say these are critical, these are non-critical. However, it's not followed. And out of that, you have this real imbalance of, and which leads back to, let's say a nurse calls and says, this patient needs X. And then it leads back to what will be ultimately the last bullet point of the fire folks having to decide, when and what resource do I send? Do I wait for that next potential 911 or do I send my last one? There's an imbalance between workflow. Now, the next 2 that we found are really related to staff. So when I look at this, I've looked at it as a system design component. I've looked at it operationally. I've looked at it financially. Now I want to talk about the workers. When we start thinking about the staffing challenges that you all have had here, 1, recruitment and cost of certain providers. So to save cost, you all started a civilian model. That's been working. Those folks are majority were brought here because of the increased expectation of that volume needed of IMH. Yes, they'll do some 911, but so will your 911 trucks do hospital work, right? So it's a balance. But those resources were put on to help that interfacility transport work. However, that still has not reduced what we call the workload on those 24-hour shifts. And really, are those trucks working 24 hours? And they're not really working 24 hours. Your staff on the street, because of market pressures and availability, and frankly, it's what people these days want to work in the fire service, they're working 48-hour shifts. If you look back at some of the studies that are going on between workloads, expectation on staff, there's been studies on 12-hour shifts, what the workload should be, 24-hour shifts, what the workload be. Nobody touches 48 hours. Okay? When you start thinking through that, you all are doing 48, but the complexity that comes in is when you have those average 3-hour interfacilities that got to go out of town, you have those 90% of the time, those interfacility transports are taking 5 hours. This could be happening at the end of the shift where, again, now it adds another complexity to where you have a firefighter, whoever's the chief for the day, goes, I got to make a decision. Do I send somebody who's been up or has to go 3 hours at the end of 48 hours? What's the risk? What's the risk piece to that? So there's a risk liability set up because of both the deployment and staffing. Last one, again, really dives into staffing workflows. When we think about staffing workflows, we think about the nurses or case managers at the hospital and the EMS chief for the day who at the fire department who's making the decisions on when those patients can and can't move. What we have found is that there's not a uniform process both at the fire service. One fire chief or one EMS chief will make a different decision one day than the next chief, which creates complexities for the nursing staff to say, we know exactly who's going to respond and when. So they're trying to figure out what's going to happen because both sides from a workflow perspective are not on the same page. And then on top of that, the reason why they're not a lot of it is because of the staffing expectation levels that have been, we'll say, imposed onto the system that really need to be ironed out so the right hand and left hand in this agreement know what they need to do. That's a lot of information in 4 slides, okay? And so that's a good spot to pause and to see if you have any questions.
Thank you, Mr. Sheridan. Council members, any questions? Okay. Yeah, please, Councilor Shumway.
Todd, I have been involved in this now for many years, and you're bringing to me in this presentation some things that are fairly creative and new, and I have a very basic question is this. You know, what you're saying is that we probably need to upstaff our ambulance for the convenience of whatever. But I'm looking at this. If there is an opportunity here for us to be more profitable, that makes sense. But if it becomes, and you're saying that we're using public funds to subsidize the ambulance service. Well, here's my question. There has been, there will always be the opportunity for the hospital, IMH, and also the county and the city to have 3 separate and unique ambulance services. And if they do, what does that, I mean, is that profitable for anybody? And if it's not profitable, I think we need to get out of the nursing and all those factors that you're bringing in and just stay with being very good at being an ambulance service with trained EMTs and make it as profitable as we can for the taxpayers. What you're bringing to me is, in this one, maybe I'm just misreading it, is there's some more moving parts that we need to go in and fix. So I guess the question is, do you think there's any incentive for the hospital and for the county to start a competing ambulance service similar to what we have in towing companies here in Laramie and Albany County? That's the question I want to have answered. Do you see any incentive for them to do that?
So here's why I'll answer it. I don't know what your complexity is for towing, but I'm going to guess it can saturate the market, okay, if you have too many towing companies, right? Because competition is good at a certain point, but the challenge point here is you're dealing with a finite set of resources, a finite set of volume. And your challenge point is if you start adding more agencies, our feeling is then you've got to add more overhead. Then you've got to add more cost. You got to add more to the system to run 2 separate systems. We believe that it's more cost effective, and we'll show this later in our presentation, to run one system. It's not going to be break even. You're not even break even on your 911. You're subsidizing that as taxpayers today on your 911. I'll show you that. But that's a cost of doing business that a lot of communities decide that there's a certain level we need for a baseline level of service, and we fund that. You do that with your fire service, right? Police officers, EMS now. The difference is in this case, you have one more moving part being the hospital service. And the hospital service in 2017, the revenues match the expenses. They don't now. And so really to answer you directly is there's a cost now that has been incurred onto the city to staff to handle those transports. And that's in the hospital transports. So if we separate the 2 moments, that's what it is. So if there's another ambulance company that comes in, if the hospital wanted to start one, if they want to contract, there will be a cost. We believe there will be a cost to them and we believe that there will bring more cost into the overall system, also diluting the staffing that will be within here available to both to the city and to the hospital, because now you'll be competing. You're already competing for staff now. My understanding is the hospital just hired another one of your staff members. So you're already in competition. If you add something else, you're going to create another level of complexity into this system. And that's why we say we think it's better if you all continue to try to work together and create this as a win-win situation.
Thank you, Counselor. Other questions? All right, Mr. Sheridan, back to you when you're ready.
Yes, perfect. All right, so we're going to talk a little bit about system design right off the bat. I'm not going to talk, you all understand your response area, so I'm not going to digest that I know your county better than you. But this really is for us to say that what we did was we came in and looked at your system as a whole. What we understood with the fire department is they not only respond to the city, but they also respond to the county, and they have the working within IMH. So there's a larger workflow and a larger expectation and a level of risk associated with this program. So in all that to say, you only have one hospital in your area, and as mentioned, if something major comes up or you have a loved one that goes there, this is a neighbor helping neighbor or an extension of a 911 call where they're going to have to be moved to somewhere else. Now, a little bit more about the design that you all have here. The fire department has its own ambulance license within the state to operate. So they're an independent company. They have leased their services to the hospital to operate. And that leasing allows the hospital to bill for them and be able to go into different billing contracts that are extremely favorable, okay, for the insurance companies to pay you all. You'll see that a little bit later, but the hospital's done a really nice job on negotiating contracts with insurance companies that have helped decrease the amount of expense that has been incurred onto the system. What you also did back years ago is there's a municipal code designed that the fire department is the only agency to operate within city limits. So now as you start to think through this, that exclusivity is a good thing. It helps you control the market space. But if you decide to fragment the system or add a second player, just know one of the pieces that you will have to work through is this exclusivity clause and either agree to allow or let another ambulance service operate within this exclusive operating. You do that in somewhat now when you aren't available and American Medical Response does come in and do some of the transports. Now, as you had heard the chief talk about earlier, this partnership has been going on for a really long time. I think I heard almost 40 years that there's been some level of partnership. Overall, this new agreement kicked in, this leasing agreement in 2017. And the leasing agreement set up in such a way that, like I had mentioned, they can bill, collect, but also had a certain level of performance expectation to the hospital. Now, since 2017, that has evolved over time. And that partnership that we have seen, so that partnership that we have seen has grown into such a way that now, moving forward, the contractual design component is in question. When we start talking about the contractual design, in 2017, I keep going back to the revenues match the expenses. And in 2022, when this contract came up, both parties said, hey, look, there needs to be a better look at this. We have invested more resources, have more expectations that we need to collectively come together to figure out a way and a pathway forward. Because ultimately what has happened is that those revenues not matching the operating expenses, no true up on the operating expense, billing costs being 7%, the hospital charging 11% of funds for administration, other costs of services coming over to the hospital. The challenge point is this agreement did not make sense. And what we've seen is this agreement has a two-part. If you could separate its current agreement into two moments, say call it a Part A, Part B. If you could separate it into what it costs to do the business, so operating expense, and what the revenues are. We feel that would be a better way moving forward, because right now you have this complexity of we're paying you a lease and then we're giving you what's trued up on the revenues after it with no look at what the cost of the expense is. Because ultimately, over the time period, you have seen a real increase in your demand of service. If you didn't realize, we've talked a lot about the hospital's demands. They've had a 10.7% increase since 2020 to now. In the middle of that's been COVID, middle of this agreement, which they purposely and collectively have decided to move forward in its old state, in the best interest of everybody, while the volumes have increased. However, you have your 911 volumes have increased as well, 10.7 or 10.2%. So you are going up and becoming more busy within your community. What you don't realize is that that overall system performance, our demands, you're running about a call an hour. So if you think about what that means, is you're having about a call an hour. You're about 0.2 of a call happening at 2 to 4 a.m., and you have about 60% or 0.6 of a call happening on average, call it 1,500, 1,600 during the day. So really you have this one call an hour that's occurring. Of that, your hospital transports and transfers, as you can see, between 10 o'clock and about 8 o'clock happen at a more frequent basis than they do overnight. But they continue to happen overnight. And what this looks at is just the demand. This is just the instant in time a call happens. We'll show you later what's called a normalized demand. That will take into account the workload that's being placed. Because that workload that's being placed on the firefighters to do the job is more than you might think when you're talking about hospital transports and transfers. Because when you think about the activity as it relates to IMH and just the patient transport, you have on average just over about 200 transports per quarter coming out of the hospital. Of that, you average about 2 to 3 transports a day from the hospital. No big issue. However, if you look at the bottom right-hand side of the screen, if you're looking at that, you'll see what's called transports. And you look from 2020 to 2023, we look at the average time on task. So from the time they went en route, or the time they got dispatched, to the time they marked available, not the time that they may come back to the community. So let's say they transport down to Cheyenne. The average time for them to come available to drive back here is 186 or 188 minutes. So just over 3 hours for one trip. That takes a resource out of your community for 3 hours. 90% of the time, it goes for 331 hours. Or minutes, so 5 hours that this happens. So you think about that. That's a resource leaving your community. And then at that point, if that's the interfacility transport truck that's gone and you only have the 2 911 trucks left and another transport needs to be done, what decision does that person make? So that's the complexity that's happening right now within your system. Now we're going to walk into what we call our demands for service. And the way we start with that is a little bit of mapping. So we took all your data for the hospital and 911 service, and we looked at it on a map, and we used on the left-hand side, which is your typical heat map. What you'll find is because of the volume right around IMH and what their volume is, that pops out as the largest hot spot that occurs within your community. Now, what we use on the right-hand side is called a commensurate risk-based mapping. It's being able to kind of take that volume that you see that makes it dense in a specific area and says, okay, how do we understand what response level should be and where they're at? And the way we do that is we dictate your high-risk areas in red based on 4 calls happening a month with 50% of its adjacent sides, a call every quarter with 50% of its adjacent sides being low risk or urban, and anything that you don't see in color is basically we consider wilderness or don't meet either one of those parameters. So you'll see the city obviously is very much in that high risk category. Now, to understand the deployment a little bit better, since you all do both the city and Albany County, we also look at what it takes to cover a said level of percent of historical volume. If you think about it just collectively, if one truck, and we're going to look at the 8-minute one on the left-hand side, In the green is an average drive time for 8 minutes. So we get that they can run lights and sirens, but we want them to be safe. So the average road speed for 8 minutes, with 60 seconds being taken off the front side, so really a 7-minute travel time, 60 seconds for muster time, you're talking about a total of 8 minutes. That 8-minute drive time, here, the first unit from Station 1 can capture 90% of the historical volume going on in your community. Going from Station 3, adding that adds 1% more of the historical volume. Now, we're just talking about covering geography. We're not talking about covering demand. Now, if you start looking through this more, you can start seeing the 12 and 18 minute, and you can see more than 90% is covered from one geographic location. That also tells us with IMH, they're covered within that same one geographic component. So if you think about just buying readiness, you're buying that one geographic component for 911 coverage to cover 90% of your calls, and you're buying one geographic component to cover your hospital transports. It's two separate systems. It's a agreement contract lease with an expectation of 911 response. So look at it as two different systems. That's going to be key as we walk through this. Now we're going to get into understanding staffing. Now let me explain what you're looking at before your eyes go crossed, okay? So these are what we call staffing to demand charts. On the left-hand side of the chart, and we'll use the one at the top, is going to be the number of units that are number of units. So you'll see the numbers 0 through 5 there, I think, or 0 through 5. I can see in my glasses. The bar charts that you see at the bottom are your demand by hour of day, day a week, Sunday to Saturday. It's 168 hours in a week. It's 52 weeks average demand by each hour of day, day a week. But then we look at what's called normalizing of the demand. We take into account the average time on task. So you'll see us talk about the average time on task for interfacility and average time on task for 911. The top chart on all these next 3 slides, the top chart is going to be the combination chart. It's the combination of units for the 911 service and combination of the interfacility. The second chart down will be 911 only response. The third one will be interfacility, non-emergency transports. The reason why we did it is we were clear to separate. We needed to understand the operational cost for each model, the revenues for each model, to understand clearly what the profit and loss is for each. Then we looked at it as a combined system. That being the design, the last thing I will tell you is the dark blue line. The dark blue line on these charts represent 3 data points. It's the geography we talked about on the previous slide. It's the demand by hour and the workload, what we call the normalizing of demand and time on task. It is those 3 data elements that create the blue line. The red line on these charts are your staffing line. We'll go through that in detail. And there's a reason why I'm getting in this level of detail for you. As we walk through this, the bar charts will change. If your staffing drops below that blue line, so your red line drops below the blue, the bar charts will turn yellow, meaning there's a risk moment. Above the blue will be green, meaning you're good. Let's start from the bottom. The bottom chart, this is back in 2017 contract. So if you were today to take today's volume on the 3 units you had back then 24/7 when this contract started, you already had 2 trucks you were operating 911, 1 truck you had dedicated for your interfacility and hospital transports. Using that same staffing model today, if you look at it, you would be understaffed, turned yellow, in the interfacility transport. That 1 truck for the service would not cover. The second chart, the two trucks 24/7 for just 911 call volume, covering those data elements, covers your service. The third chart combined, which is the 3 units at the top, you can see collectively with today's volume at the 2017 contracted level does not match system design, our system needs. Moving forward to the next one. So if we took 2022 staffing, you all invested in civilian staffing. You added a peak a day truck to help with the demands. Even though very little volume, you only saw a little bit under. However, what you will notice clearly is on the bottom, as you added that I'm going to call it a half truck, a 12-hour truck, you still at nights are understaffed to meet those variables that we talked about. So what ends up happening collectively is, let's say that peak a day truck goes home. Let's get really tactical for a second. That peak a day truck goes home, and you're the nurse, you call me and say, hey, look, I got this transfer, and I'm sitting in the middle of the night. I already got a 911 call going on. I got to make a choice. Do I send my last truck? Do I not? How do I move? How do I navigate that? So in the evenings, what's happening is there's a lot of conversation going on, and that's where some of the complexities happening within the system is that level of demand has increased, the expectations aren't clear, and because right now it creates a variable moment in discussion. Because if you look at the second chart, that's still 911, you're covered. And then if you look at the third chart, collectively they're covered with a few risky hours. However, what becomes very interesting and telling is you can tell now somebody's having them to make a decision when and where and which patients get what resource. So the last slide. Now I'll stop and take questions after this. So this last slide is what we've put as kind of, we'll call it an optimized model. If you wanted to cover the two systems separately, the 911 as you do today, 2 trucks, but to limit and reduce the amount of complexities that you have in that risk liability decision point that's going on between both parties, both the hospital and EMS, we believe that 4 units 24/7 could help eliminate some of these challenges for you. Now again, there's conversations, there's contracts, you have to work through that with your partner, because there is a level of cost associated with that. But this helps to reduce the complexities within the system, treating both of them separately and allowing for that workflow to continue. So I'm going to pause there, take a sip, and see, Mayor, if you all have any questions.
Thank you, Mr. Sheridan. Council members, any questions? Great. All right. It's a fast sip, but we're back to you.
Let's go.
Thank you.
All right. This one I'm passionate about, and I'm just going to say this because I originally did not have this in the slide deck, and I think it's bearing being policymakers to understand what's going on nationally. I kind of threw this in last night, I'll call it for lack of better terms, because I'm going to go into the finance next, and it's going to bring light the cost associated to really run the program. We've seen lots of systems over the years where private entities have gone in and run 911 services and been very profitable. But if you've started to pay attention, and I don't know how much Google searching you've done about the EMS industry, you're going to hear terms like ambulance deserts. You're going to hear terms of we're having to close our doors. We need to merge because we can't sustain our costing. We need subsidy. We're seeing hospitals that we've worked with change their performance expectation because, as I told you, performance drives cost. So instead of wanting them in 30 minutes or 1 hour, now they're changing to where certain calls only need to be there in 2, 3, 4 hours or they're starting to pay for the service. They're starting to say, we are going to pay for this level of service. That's not unique to hospitals. That's actually unique to municipalities too. There's a large municipality that we're working with right now that had no subsidy for years. And that ambulance company came to the city and said, hey, look, we can no longer fund ourselves. I've done 3 procurements lately that we do RFP processes, and that were services that did not cost money, that they were free to the cities and municipalities and counties. And each one of them at the end ended up with a subsidy. The cost shift at the national level the costs have not at the national level, at Medicare, Medicaid, even commercial insurances. Now here I will say your hospital's done a good job negotiating your commercial rate, but the reality is at a national level, these costs have not stayed in line with the cost to do business for EMS. It's just very simple. We've all seen wage increase. We all knows what happened with inflation, but this started well before we've had our Sentinel event over the last few years. this was already, we were showing on this slide, shows back from 2017, the cumulative change between CPI and our CPI and Medicare. And you'll see before COVID, 2020, in just those few years, 4 years, we were behind 7.7% with just CMS rates. So just to give you
Mr.
an
Sheridan,
idea.
Counselor, sorry to interrupt, but.
No, please.
Yeah, because I don't Google this all the time. What's CPI?
Oh, Consumer Price Index, inflation.
Oh, that's
Thank you.
CPI.
Yep,
Okay.
yep. No worries.
It was a hospital
Sorry.
term.
No, no, that was just my finance brain and kept running. But just so you know, the inflationary moment CPI has not kept up with the expense to run the system prior to COVID, and we all know what has happened since then. So I wanted to just let you know you're not unique in that you're living the same problems other municipalities are living. I feel like I have to give the same conversation to people week over week, but it's just unfortunate. This is where we are. It's being pushed down to the local municipal level to set what you want as expectation, what you're willing for costing, as well as that's happening to hospitals as well. So we're going to dive a little bit more into the finances now. So as I mentioned before, in 2017, this was a win-win. And I keep saying that because it really was. But with that peak a day add-on and not enough volume and having no operational true-up along the way, unfortunately, what happened in 2017 has not really been able to, or has not allowed for, or the contract in 2017 has not allowed for just this organic growth and change within the agreement to really make sure both parties had a win-win. The other challenge point that we have is both parties do not interpret or collectively share an understanding for the financial modeling. I've worked with both parties, and neither party, as it relates to what, and I'll tell you, we do this same financial modeling, agency after agency after agency, procurement, hospitals, we work through that both operationally and financially. Neither party here collectively had come together to have a good model at the onset of 2017 and to now, into where, especially in this contract term, everyone's collectively come together and worked through and understood what that financial model needed to be. How they made sure the operational component was trued up, how the billing was applied with, the billing costs were applied, how that true up occurred. So moving forward, that's why we make it very clear. You have an operational component within your agreement that has a cost. You have a billing part that they collect everything monthly, and whatever is collected over the expenses owed within the contract should be transferred to you. There's two cost components moving forward for this. That was not in the 2017 agreement, and as we start walking through, that's what we would suggest moving forward within the next agreement. Now we talk about 2021 revenues. Now, if you think about it from 2017 to really now, and we'll show you in a little bit, but your revenues have increased. That revenue true up, we're going to call it, has increased as well. However, that revenue true up still is well below your operating expense. The other decision point that's very interesting is the hospital is charging you a 7% for billing. That's a little bit on the higher side, but not outside the realm, okay? There's a lot of also good work that they have done on helping through this partnership on getting you better commercial and contractual rates. So they're a good partner on that and helping you. However, they apply on top of that an 11% administrative fee. That administrative fee is not something we typically see with an outsourced contract. However, that's something between what they have done, what you all have negotiated, was put within that agreement. Part of why I say that to you is if you start talking about and start making policy choices that say, okay, we're going to separate from the hospital and not do their work, there will be a reduction in revenue per transport on your commercial side because you'll no longer have those same rates that the hospital's negotiated for you. Okay, I want to make that very clear because that comes into a costing component as you start thinking about what your model might be moving forward. Let's talk a little bit about financial methodology. The goal of this for us was really to understand your cost of doing 911 and the cost of staffing and covering the hospital contract. That's really it. So as we work to break this down, we also try to help mirror and bring into the understanding of how municipalities budget and how the hospitals budget. So we worked to get collective information from each one of them. I'll tell you, that was a really good exercise to see both parties and where they were coming from. They provided a tremendous amount of data. The finance folks here in the city provided a lot good analysis that we were able to break down further. The hospital did the same. It was a lot of data collectively coming together, probably for the first time in a while, to help build what this model could look like. The challenge point is both parties have sat down, but at the time had really, we'll call it to no avail in discussions. It was able to harmonize the financial process, which has really hindered their next steps in closing out an agreement. So our goal was really to help set that platform. And I'm not going to say everybody agrees with my findings. But what I will say is this is the same process we use across the country, same process we manage with. So we're going to bring that and we're going to apply that here as we work forward. Now, as we work forward, we're going to build out the revenue. We built out a revenue calculator that said this is what the hospital, what they're collecting today, average revenue per transport, and if you went away from them, what that revenue per transport would be, which is reduced. We did also look at and made some cost assumptions and divvied up based on the total number of units that were operating within each area, the operating cost, the operating expenses, and the depreciation. Through that, we really broke this down into 7 different models. After we separated the 911 and interfacility transport operations, we then broke this down into where we look at the city fire department handling at 1 truck as it started in 2017, that one with a peak a day, so we're going to call it 1.5 trucks as they are currently, and then what the finances would be if you went to 2 trucks. We then broke it down if the hospital decided, hey, look, we need to move away and we need to bring in maybe a private company to run this. How much would that cost the hospital? Because the hospital did at one point go out and look at bringing in a private entity and then in some subsequent way and for some reason came back in and had further discussions to continue this lease agreement in some fashion. But we had to understand why that potentially could be and what that cost to bring in a private company would be to the hospital, because there would be a net impact to the hospital as well. We also looked at as the city fire decided to continue doing the operation, but because of the billing complexities, the cost, the percentage, would it be more beneficial for them to still do the work, but outsource to a third-party company? So we looked at all these different models so that, one, we could provide both feedback to both clients, since we're kind of the middle objective party, and also be able to give you as the policy leaders. Now this next slide is crazy busy, okay? So as I'll walk you through a little bit of this. The following slide is a consolidation of the profit and loss for you. But at a high level, when we walk through this, what we will see is the revenues that we put together and the volumes were directly provided to us from IMH. So this is the exact average revenue per transport and the exact volume they provided. We looked at it both from the 911, separated by call class, the revenue per transport, ultimately what the medical transports were, so the ones that or the patients that stay within the city, the ones that leave the hospital, maybe go to a nursing home or go back home for care. We then looked at it from the hospital transfers, the ones that go out to Cheyenne or into Colorado. We looked at your helicopter transports, and we also looked at your county subsidy. Because the city gets a subsidy from the county of about $275,000 to operate on the 911 side. So on the 911, the 2 models that we looked at here, both of them have what we consider the cost of service. Now in the revenues, we lessed out the cost of each one of those models with the hospital doing the billing. The hospital, out of the revenues they collect, immediately take their percent and give you what's left over. So as you walk through the financials, you'll see we did that same methodology to follow their same process. From an expense side, what we built up is we then built up each of the varying models. We said, okay, we're going to look at 911. And if you look at 911 specifically, right now, as a community, to staff those 2 trucks you do a day, just to cover 911, the taxpayers are paying about $1.8 million a year buying that level of readiness because the revenues do not match the expense. Okay? So as taxpayers, basically you are subsidizing, which is very normal across communities. I want to say that's not abnormal. So after we separated the 911 side, we went and looked directly at the inter-facility transport side. So then we broke down both the hospital doing it at the current, or the 2017, then what we call the 1.5 units, and then 2 units. And I'm going to go through the exact numbers of the cost here on the next slide because it's much bigger and everybody to see. Then we separated the private model, and again, then we separated both the hospital, still working with the city, but the city using another billing service to eliminate that complexity in the contract. I just bring this to you as the level of detail. There's a lot of supporting behind this. We've worked with both parties as to walk through this specific model. And as I mentioned before, not everybody's in agreement, but this is the way we have done. As we manage, we walk through with varying parties that we consult with, which we do about 100 a year. So in short, this is a little bit easier for us to digest. So these numbers here are reflected off your 2022. And they're only showing the cost it takes as you as a city to operate this inter-facility transport and hospital transfer lease agreement with the hospital. This does not, I want to be extremely clear, this does not take into account your work on 911. Okay? I want to be extremely clear with that. What we built you out here is about 8 different models. And in the models here, we just arranged them from the least costly to the most costly. The least costly that you would have is the fire department still doing the hospital work, both with sworn and civilian personnel, just like you have today, with 1.5 units covering, so that 1 truck as you do today, just like the one and the current 1.5 truck. So your current cost, we believe, is somewhere around $645,000. That cost you're incurring from the taxpayers to staff your trucks to support this lease agreement with the hospital. From that, you'll see if you take and just the fire department with IMH still doing the billing, of course, and just fire department personnel, so all sworn, costs about $827,000. If you look at this from the hospital doing, but having 2 trucks 24/7. 2 trucks 24/7, it's just over $1 million. So if you wanted to go and add another 12-hour truck, there's no more revenue. There's no more volume you're gaining out of this. It's just an expense to cover that risk on the other hours. That increased cost will bring it up to basically a loss today to the city of about $1 million. If the hospital, the next cheapest would be the hospital going out and potentially looking at a private model. We made some assumptions of what some private costing would be, and it would cost the hospital about $1.05 million a year. We continue to move down, and we keep looking at both fire department doing billing and without billing at 1.52. But you can see the incremental increase all the way up to, depending on the policy choice you all made from a contracting perspective, what the cost the city is incurring if there is no payment for the operating expense from the hospital to the city. So that's where we're saying that expense supersedes the revenue, and where you're still having to staff, you're still paying for your vehicles, you're still paying for your people, that expense is being incurred by the taxpayer. So I'm going to pause there before I go into the options moving forward to see if you have any questions.
Councilors? Councilor Richardson, please.
Thank you. Just a clarification. So on this chart, it says cost to IMH annually. and then has the 600 plus. But we are looking at that also, we're not subsidizing with taxpayer funds. I finished reading. We're good.
That's okay.
All good.
No worries. I'm still trying to figure out where to look in these glasses, so I'm like over here looking like a bobblehead, I feel like, as I'm trying to read, so
It's my glasses.
it's okay.
Thank you. All right, back to you, Mr. Sheridan.
Thank you, Mayor. All right, so as we start talking about we put 3 options together. Now, as you can see, there's different costing models for each one of those options. But in the true sense, when we think about this, option 1 is what we said at the beginning. If you all can figure out a win-win, you can get the finances right, you can set the operational workflow, we believe it's best for the community if you all come collectively together and figure out that win-win. We think it's best for the operational piece. You can balance it with the hospital. You don't have competition within the market space. The way you design your exclusivity, our code, that still all plays well. All of those pieces, if you can create that win-win with the hospital and you all can come to an understanding of what the costing should be, then we believe that is the best option for you all to move forward. However, that's not something you all choose as a policy option. Option 2 is basically you all get out of the transport business as it stands. Now, there's some pieces to that, and I'll explain the risk to that, both on you all getting out of it, market space challenges that you're going to have, and what we call effective fire force. So we're going to talk through that in a minute. And then your option 3 is the Laramie Fire Department continues to do it, but because of the billing challenges and that complexity of how the revenues and this true up of revenues but not expense, if you can't come to agreement there, but you can still come to agreement operationally, then outsource it, take the financial loss, but you'll have to transfer some of that, or you'll have to transfer that cost within a contract back to the hospital. So at a high level for option 1, what we believe is that you can get, or the issue is that the current agreement is not a win-win. It is, as we've mentioned, financially, it costs the city to operate for the hospital. However, if you can move this forward and you all can come collectively together and you can, again, outline, we'll call it Part A, Part B, what the operational cost is and what that money is per month or per month and year you're owed, and what that true up is of revenue and how they bill, and that they should be billing or providing you the exact amount they bill each month to you. If you can collectively work that together, we believe that you all could come to a win-win situation for your agreement. Now, option 2. Not the most cost-effective, as we believe the issue with this model is. It would split resources and it would create a situation where you're adding another provider, you're adding another cost. Imagine competing now for more salary dollars, whatever that looks like, overhead, vehicles coming in and out, code changes. There's some complexities here that you would have to work through. You wouldn't have as much flexibility, as my understanding is there can be situations around here that can be taxing on the system. The challenge point here is one collective group operating together. If you can get on a common operating plan, you can get your workflow set, you can really create a win-win. But if you can't and the system separates, it'll make for limited flexibility in the system. As you start talking through that, another risk to the city is moving away from the hospital will reduce the revenue, ultimately creating more of an expense. So those are some of the pieces that we see moving away. You also have to understand is there's things called effective fire force, and you need to make sure that you have a dedicated level of firefighters while you have your civilian model to also be able to operate, and being able to, or depleting that could affect you both operationally and financially a separate way. Option 3 at a high level. Again, this is really, if we look through the most costly model, not only are you getting the revenues or not getting the revenues from the hospital, but you still own the expense. So not having that higher revenue per transport that the hospital is negotiating, going to an outsource, becoming what we call non-par, not within contract with a insurance company. And the leverage they have that they can negotiate versus what you can you're not going to be at the same leverage, and you're going to be at a disadvantage. So the reality is for them, if you were to remove that situation and go to a third-party biller, and you still have that same expense to operate for the hospital. It is the most costly model within the three. It still allows you, though, to have one system with less complexity, but it's a policy choice that you all would make both operationally and financially. And with that, I'll take any questions.
Thank you, Mr. Sheridan. Council members, any questions? Councilor Shumway, and I guess before we go, I would remind you all that we are actively in negotiations here, as a note. Councilor Shumway.
I think you've tried to explain why the cost would be higher if we tried to do our own billing. I think a big component you said is because we don't negotiate, we probably would not negotiate as strongly as the hospital has already set up that relationship. I see a $300,000 to $400,000 difference between the city doing the billing and our agreement with the hospital. Now, I know that most of the funds that come for transporting come from Medicare, Medicaid, and also then you said the private insurance companies. I find it interesting that the hospital ends up getting 17%, the 11% administrative, and or it's 18%, and the 7% for billing. Yet we can't, you don't feel like that the city would be able to negotiate within 18% of what the hospital does. It would be a $300,000 or $400,000 loss for us. Well, I don't disagree because you're the professional, you do that. The one thing is, I think the biggest loss that the hospital has is probably not collecting, it's those that they cannot collect on, the people that don't pay. I think it's like 30%. And so that becomes a very big hit. But I don't know who takes the most responsibility for that, the city, or if it's the hospital, or if we just share it 50-50. The analysis that you have, for us to be, you've given us a lot of things to think about. One is to increase to the two system that you have, so we have that. But I just don't see how these insurance companies can be so difficult to work with that it would cost us $300,000, $400,000, $500,000 just to negotiate with them on what has already been established for Laramie through the hospital. I don't understand why that jump would jump so immediately if the billing goes to the city of Laramie. And maybe you can shed more light on that they, that's the option, that they can do it, and that somehow the hospital has more leverage than we could possibly have with them. If you could explain that further for me, I'd appreciate it.
Yeah, in short, the hospital actually has way more leverage because they can say, okay, I'm going to negotiate, let's say, this service and this one collectively together, and ultimately combined, they can create a better bill. Okay, that's just the shortened version of it. They have the opportunity to leverage between all the pieces and parts they're negotiating with insurance companies to create a better rate. You're negotiating one piece, and the first thing that would happen is if you don't have that contract, and I'm telling you, there are a lot of insurance companies right now that are going from what you're getting paid right now, which is, if I remember off the top of my head, almost 2-3 times Medicare rate. A lot of insurance companies are negotiating down to Medicare rate. They're like, well, if the federal government's there, this is where we need to be. So the insurance companies are actually reducing that. And so when you go from being contracted in this situation, where they have leverage, even if you went non-contractor, you try to go separate, we're not seeing nearly the level of success that the hospital system has had. That's the reason for that delta. You also touched on a piece for it earlier, the bad debt. So there's two parts to bad debt and not paid. When we start thinking about that, is Medicare and Medicaid are capitated models. They're only going to pay you what they're going to pay you. Okay? However, your charges, no matter what, are going to supersede that. So anything between that delta of what that capitated rate is considered bad debt or write-off. And so that's just money you're not getting. So when you hear 33% not collected, it's not truly not collected. I'm going to tell you, IMH does a very good job chasing down your pennies, okay? They really do. I watch billing companies. They do a very good job chasing down pennies. But that level of bad debt is really designed and reported out on really capitated rates. And so that's what you're seeing. When you see that uncollected, you'll have it on that. And there is some uncollected on self-pay that we recognize only single digits worth of people actually pay on self-pay. So there's a lot of write-off that goes there as well. So I just wanted to answer both of those for you.
Thank you, Counselor. Other questions? Counselor Richardson, please.
I have a slightly kind of one-off question. I think this is for city manager. That 1.8 that we get for 911, does that come from county property taxes?
Mayor and Council, through you, Mayor, Councilor Richardson, our 911 response is supported through general taxation that city collects. So
Okay.
through our 8 mills
Okay.
and through our sales tax, sales and use tax, I should say. Now, as Todd had mentioned, we did, for the first time ever, I think 3.5, maybe 4 years ago, successfully negotiate with the county for that $275,000 transfer they make to us to recognize our work that occurs extraterritorially out in Albany County beyond the city limits.
Great.
But in general, it's just general revenue that supports this, as supports all of our key governmental services like police,
Okay,
fire
thank you.
response, et cetera.
Thank you.
Thank you, Counselor. Other questions, Council? Counselor Pierce, please.
Yeah, thanks. And Todd, this isn't for you, this is for our team. I'm wondering if you could update, or if you know of any updates based on perhaps state legislation or issues related to this, because certainly there have been discussions at the state level, knowing full well that there is a desert, or whatever the word we use, for EMS, ambulance services throughout the state of Wyoming, and we know there's been discussions at the legislative level. So I'm not up on anything current, and I'm wondering if you are aware, or perhaps anybody is aware of anything at the state level at this point.
Mayor and Council, through you,
Please.
Councilor Pierce, there is the allowance in statute for an ambulance district. I think the cap is 3 mills. That has not been imposed. We have looked at it and we have discussed it with our partner at the hospital, but it would require a vote of the electorate. And also, there is some uncertainty as to whether, if that millage were imposed and approved by the voters, if it would then have to be subtracted from the city's maximum 8 mil. And so there's some uncertainty there. So I'll say that is in statute currently. What I would like to offer is, if Commander Hotchkiss or if Chief Johnson would like to add anything, we have some experts in the room serving on state committees. And you are correct, ambulance deserts and ambulance services are an issue all around the state. I think 911 response, insofar as I know, is solid around the state, less in jeopardy than patient transfer. And so I would say, in my experience, I think we're similar to the rest of the state that way. The exception being, this city has sufficient resources to provide the highest level 911 emergency response, and has always prioritized it from the council level to the staff level. I think where we're struggling is in the transport section because of the distances and times required. And Mike and Dan, if you want to add anything, please do.
Thank you, Chief.
Well, Mayor, Councilor Pierce, can you restate the question? I think City Manager answered it pretty thorough. I'm not aware of any districts being formed under that legislation yet in the state. I think you were asking that. So I don't think anyone has yet.
Okay, thanks.
All right, thank you, Chief. Other questions, council members? Okay. Great. Thank you, Mr. Sheridan.
Mayor, Council, thank you all so much for having us. We appreciate the partnership.
Yeah, we appreciate the work you're doing for us. Thank you. City Manager.
Thanks. So, Council, I'll close this out for us real quick. I would like to note that Mr. Sheridan uses a phrase that what we're doing now, based on their analysis, the partnership we have, is the most preferred option. And what we asked them to do when they came in to work with us, at least from the city's perspective, is prove that out to us, frankly, right? Is what we are doing currently, the partnership we have, the best option? And I think when Todd says that, and you can correct me if I'm wrong, but I think what he means, is it the best option widely and collectively for the community and the residents of Laramie and Albany County? And so I would tell you that as we have looked at the analysis Fitch has brought us, they have proven to us that continuing to partner with Ivinson is going to be the preferred and recommended option of your staff team. A couple things I wanted to share with you as we close this out. We knew a few years ago that the city's costs were increasing really more rapidly than is sustainable in terms of both 911 response, but also for inter-facility transfer. We were all experiencing something that was very remarkable and nothing that we expected, so we have let it ride, so to speak. And the council has been amply supportive for the last few years in authorizing additional monies to shore up and support 911 response and interfacility transfer. I'll share a few numbers with you. Just since the last biennium, we've seen our personnel only expense in EMS increase by $750,000, and our expense in fire. And when I say fire, I mean fire sworn personnel, but remember, they are dual purpose. They perform EMS services as well. We've seen that go up by $400,000. Some portion of that is related to just labor costs increasing for those civilian paramedics and civilian medical staff, as well as for our fire sworn staff. But what I can tell you is the resources that we've had to shore up the system and sort of carry it through the experiences we've all had in the last few years, in part, I feel like we're supported through some COVID relief that was one-time money. And it is, as I've told you in our budget conversations, likely unsustainable for the city to continue adding $500,000 to $750,000 of expense on an annual basis or even on a biennial basis going forward. So where are we at right now? We've expressed to the hospital, our counterparts there at the hospital, that we would recommend to you and have been working toward option one, which is finding a way for this partnership to be win-win financially, sustainable long-term for both parties. And we do have a conversation going on with Mr. Faust, the CEO at Ivinson, and also with James Bann, his CFO. I think we're going to meet again in a few weeks and kind of pick that up from here. But for tonight, it was my hope that we would bring the council up to speed. There's been so much going on, so much detail, and so much information. Hope we didn't overwhelm you, but I hope we gave you a sense of kind of where the financials lie and what the situation is in terms of staff burden and demand for workload in the fire and EMS section. I would be happy to take any questions that you might have. Certainly, we'll come back and update you after we have the upcoming meeting with the hospital staff. My goal was to conclude the renegotiation of this contract and have a new one in place in the first quarter of this calendar year. That clearly has not happened. And so right now we are hoping by the end of Q3 of calendar year 2024. And the urgency behind that is going back to what I've said. The expense here is maybe unsustainable for the city over the long term unless we reach a win-win solution.
Thank you, City Manager. Council, any questions for the City Manager? Councilor Pierce, please.
I don't have a question, I have a comment.
That's fine.
Yeah, thanks for all your hard work on this. And we are aware of the increase in expenses. You've kept us, as council, very much aware of that for the last couple of years, so we know. So we hope we have a really good decision at the end of the third quarter, Q3. So yeah, so thank you for all that you've done.
Thank you, Councilor. All right, and Mr. Faust, if you'd like to add anything to this conversation, you're sure welcome to as well. Yeah. Yeah, sorry.
No, I'm good.
Okay. Great. All right. Councilors, with that, I suppose we can take public comment on the work session if there is any. Members of the public, go ahead and raise your hand on Zoom or come forward in the room.
Sorry, I changed my mind.
Have at it. Come on up.
Thank you. Good evening. My name is Doug Foss, CEO of Ivinson. that's the punchline. We didn't accept the report from the consultant. We're not in agreement with it. So, I mean, we full-heartedly will have a conversation. Janine's staff reached out to me today, so we will meet in a couple of weeks to try to work through this. But I just think it's important to say we do disagree with the way that the consultant has allocated cost from basically the fire side over to the EMS and the 911 side. It's if you add up the FTEs, you wouldn't have enough FTEs to support a fire department because a lot of them have been allocated over to the EMS and 911 side. So I'm not sure where your remaining fire staff is. So that's our primary disagreement with that report. There's a lot of good things in the report, but that's really was our sticking point.
Thank you. Councilor Newman? Are you okay to take a question?
Sure.
Well, my question is probably for city staff
Oh,
anyway,
okay.
so.
Thank you then.
We don't have a page 33, so is there another report that we don't have?
Mayor and Councilor, there's a full report. You saw a synopsis. As you can see how complex it was. Obviously, we weren't going to walk you through 50 pages of reporting, but we're happy to send you the final report. Fitch Counter, Dan will do that. Yeah, absolutely. I just want to offer this. Let's bear in mind that your fire department, in terms of sworn fire department, is probably 1/3 understaffed compared to national standards. And where we have added staff, we've added civilian paramedics. There is clearly a misunderstanding of cost allocation. Thank you.
Thank you, City Manager, and that is understood by the council. All right, we will go ahead and close this work session, council, and with that, we are adjourned.